Right, back live tonight. You're in Focus. A Deming report has found that the Free State clinics are battling with poor facilities, critical systemic issues, long waiting periods and unprofessional staff. Data released annually from the Ritshidze Community-led clinic monitoring group reveals that only 17% of people with HIV receive a 3-month supply of their anti-retroviral medication. Ritshidze Project Coordinator Ndivhuwo Rambau joins us now for more on that. Ndivhuwo, good to have you and thank you very much for coming on. As I mentioned, you are a community-led monitoring system as opposed to a research project, maybe, if you like. So you are not testing hypotheses. What makes your data to be better data and I suppose more usable?
Okay, so thank you. We are from a consortium called Ritshidze, which is made up of 5 people living with HIV organizations, namely the Treatment Action Campaign, Sanarela Plus, NAPWA, Positive Women's Network, Positive Action Campaign, and we come together to monitor HIV and TB services in healthcare facilities to understand the challenges that people living with HIV as well as general recipients of care go through in order to attain either the life-saving ARV treatments or just in general what the actual experience is on the ground when you are visiting a public healthcare facility.
Yeah. Are there any limitations to your reporting approach?
At the moment, we only monitor plus minus 400 facilities across 8 provinces in the country. As we said, we're not testing any kinds of hypotheses, but we are rather looking at the red flags, things that can be fixed within a facility or at a district or a provincial level to ensure that we actually improve and are able to attain our 95 targets. It's not that we are whistleblowers or we are trying to find all the wrong that the Department of Health may be doing, but rather we want to fix the healthcare system so that we find ourselves attaining the 95 targets and also be able to reach that target of ending AIDS by 2030.
So you identify challenges, generate solutions. That's really where you are by engaging those who are duty bearers. Let's firstly look at this particular report. Some challenges as far as staffing is concerned. You're saying in the 23 facilities that you've looked at, 143 vacancies. That is the symptom. What is the actual cause of this staffing gap? What are the managers saying?
So the shortage of healthcare workers at our clinics remains a crisis still, and only 20% of facility managers that we spoke to across 51 facilities in the Free State and quarter 3 indicated that they actually have enough staff on hand. And with there not being enough staff, we find that in some instances, they are saying that 44% actually blamed one or more unfilled vacancies. Some say that they just don't have enough vacancies within the facility specifically. And at the same time, we know that we've got our district support partners who are from PEPFAR, and 57% of facilities indicated that they would like their DSPs to also assist in bridging the staff shortage bridge. So that would be Right to Care and VITS RHI as well. And with there being all of these staff shortages, there's a knock-on effect now on the waiting times where people are now waiting much longer because facilities do not have enough staff in some instances. At the community meeting yesterday in Thabo Mofutsanyana, we heard that a particular recipient of care ended up being tended to by a cleaner because the nurse indicated that they are quite tired. So this also leads to issues of burnout for facilities, for staff members as well, which also then leads to issues around staff attitudes as well, because nurses are also people as well. They also will get overwhelmed and overburdened as well.
So are you saying that looking at this report and compared to your previous report, is showing no signs of improvement?
Well, in terms of improvement, there is some slight improvement in terms of the waiting times. So waiting times have gone down. We are finding that people are now waiting for an average of 4 hours and 32 minutes at the facilities. And when we calculate these waiting times, we calculate from the time a person arrives at the facility, but we also do recalculate that and also have a calculation on the time that the specific facility opens, because with engaging with the department, we found that the department has their own measures in measuring the waiting times and wouldn't consider a patient who's arriving extremely early in order to get seen on time, because that is something that is happening where people will start queuing outside the facilities as early as 5 a.m. so that they can be first in the line, so that they can also be seen quite early, because there's just this notion that as people living with HIV, you should be living to go to the facility. But people living with HIV also do have lives. People living with HIV do need to go to work. So it also then leads to this perception that people living with HIV must just always be at the facility. You can't miss your appointment, because if you do miss your appointment, you will be met with some punitive actions against you, like being sent to the back of the queue or not being seen on that specific date and told to come back on another day because you did miss your appointment on a certain day.
Are you saying that part of the reason also is the fact that you have very poor filing systems? I don't know whether you're saying 57% of them have got it right, or is it 43% that have got it right? But I'm just trying to find out, those that have got it right, what is it that they're doing that the others that are not doing?
So in most instances, we are finding that the filing systems are not as good as they should be. And this is due to either issues of space. You find that there are not enough staff members who are actually allocated to be working with spouse files specifically. So once a recipient of care is at the facility, they're done with their session for the day, a file might not be returned where it needs to be. So you'll find people who are using clinics indicating that, look, at that clinic, I've got more than 3 files. My file did get lost the last time, and then I had to wait for the file to be found, and eventually I had to use a piece of paper, for example, meaning that that person's medical history has now been lost. So as a person who is living with HIV, who you would be collecting your treatment at the clinic, it's good to have your medical history to understand if you maybe not had any kind of complications in terms of your treatment or which regimen you might be on. And some of the key solutions that we've indicated is that let's move people to a longer refill length. We found that in the Free State, a majority of people are actually being given a 2-month refill length in terms of their medication. And if we move people to 3 to 6 months, we find that we'll be able to decant our facilities. The facilities will be underwhelmed. We won't have as many people going into the facility just to collect their treatment. And we say when we say let's decant these people, we are saying let's decant people who are stable on their treatment, people who are adhering on their treatment. And I think we'll see a very big difference in terms of the numbers of people coming into the facility if we have more people being decanted out of facilities and also getting a longer supply of their medication as well.
So you've already mentioned the question of morale being part of the staff shortage, making staff work longer hours. But is there something else to this culture of unfriendliness? You know, sometimes people just assume nurses at clinics are just unfriendly people. Is there more to it that you're finding as far as your monitoring is concerned?
I mean, when we look at key populations specifically, we found that people who are queer or trans or people who use drugs or even those who engage in sex work and often feel that or face very uncaring and, disrespectful, cruel, and even abusive treatment at public health facilities. So sometimes there is that aspect of wanting to impose your general religion or how you view the world. And this makes key populations very uncomfortable to actually go to facilities and actually seek services that they may need or require. And we're finding that most key populations are actually using public health care facilities in order to access their health services. And in Free State, only 47% of sex workers said that clinic staff were actually always friendly when they came to seek services in the facilities.
Yeah. Was it surprising for you that there was a degree of a lack of treatment literacy?
The thing with treatment literacy is that treatment literacy helps people understand the importance of taking treatment as prescribed. And as much as 86% of people that we spoke to in the Free State who are living with HIV received a viral load test, it's important to actually understand what that viral load test means. What are those results actually saying? It also now speaks to the U equals U messaging, that if facility staff are not sitting down with people living with HIV who've gotten their results back from their viral load, to be able to understand what is it exactly that is happening within them. So in instances like these, we also would like to plead with the department that let's work together as the PLHIV sector. All of these organizations that have come together to form Ritshidze are more than willing to go into facilities, do health talks in the mornings, in instances where facility staff are really, really busy and aren't able to share all of the vital information. So if these sectors can come in the morning, do their health talks, talk about the importance of adhering to treatment, talk about HIV prevention tools as well, I think it would go a long way in people understanding the issues around U equals U and HIV prevention as well.
Yeah. Infrastructure and clinic conditions. I mean, some dirty facilities and so on and so forth, that's a symptom. There is probably a bigger issue that is underlying there that leads to dilapidated infrastructure and unmaintained and unsanitary conditions.
So I think the first thing that we should talk about, even though we're not really experiencing it as much now, is the issue of load shedding. There are a lot of community members who came out to say that, look, when there is no electricity, we can hardly even access our treatment when we go to the facilities. And then going in terms of facilities actually being in a good condition, we're finding that communities are also evolving. Communities are changing. In most instances, we have people who were either, using the facility as children, also having their own children now and going into those facilities to seek services. So communities have grown, yet we find that with infrastructure, that is not the same, thing that is happening at the same time. So we are finding that facilities are overcrowded, facilities are in need of renovations. The WHO standards indicate that there's a certain catchment area that a facility should be serving, but within migration, with people moving in, with communities growing bigger, we find that facilities are not able to keep up with that specifically.
And when you are engaging then the duty bearers, are they willing to engage with this data and actually do something about it? Especially, I mean, this level is at a primary healthcare level where we're saying, let's fix things there. Then you won't have such big issues when you get to the hospital level. Ndivhuwo? I think we've lost Ndivhuwo there on that connection, unfortunately. Technology there letting us down as we were about to wrap up that conversation. Right.